Good afternoon, everyone. On behalf of the Committee of Dystonia Network of Australia, we would like to extend a warm welcome to Dr. Florence Chang, who is going to speak to us today about occupational and musicians' dystonia. Dr. Chang completed her medical degree at the University of New South Wales with honours in 2002. She completed basic physician training in St Vincent's Hospital, Sydney, then completed advanced training in neurology at Royal North Shore Hospital and movement disorder fellowship at Westmead Hospital. She completed her neurology fellowship at Mayo Clinic, Rochester, Minnesota, in the United States in 2012. She then spent a year at the Movement Disorder Fellow as a Movement Disorder Fellow at Mount Sinai Medical Center in New York City, New York, where she was awarded a Clinical Movement Disorder Fellowship by the Dystonia Medical Research Foundation.
Currently, Dr. Chang is working as a neurologist at Westmead Hospital and has more than 10 years of experience in Parkinson's disease, advanced therapies such as duodopa intestinal gel, deep brain stimulation, and apomorphine injections and infusions since 2010. She co-authored scientific papers in the Natural History of Dystonia, Huntington's disease, and the quality of life of Parkinson's disease patients on duodopa therapy, an improvement in freezing of gait and dyskinesia of patients on 24-hour duodopa therapy. She completed a postdoctorate research degree at University of Sydney on the pathophysiology of dystonia in 2020. Dr. Chang sees Huntington's disease and Parkinson's disease patients at Westmead Public Hospital and general neurology and movement disorder patients in private rooms at Westmead. Her topic today is musicians and occupational dystonia.
Thank you, Kerry and Lorraine, for the kind introduction, and thank you very much to Dystonia Network Australia for the kind invitation. So I'll give out our outline about the history of musicians' dystonia and define dystonia, followed by a talk about its possible underlying causes. And we'll show some video segments of what dystonia probably will look like. And also talk briefly about treatment and upcoming research findings. And so initially, dystonia might have been describing a pianist, Robert Schumann, in his diary in the 1830s. And later on, a famous neurologist called Goers, he described focal hand dystonia in musicians. And back then, dystonia is thought to be a psychogenic or stress or depression, anxiety-induced condition, until in the 1980s when a movement disorder neurologist, David Marston, and Dr. Sheehy, they described writer's cramp as an organic cause of dystonia. And so that was then accepted as an organic condition. And Leon Fleischer, who's a famous pianist, he came out and said he also suffers from musicians' dystonia, and that has significantly impacted on his performance as a pianist. So as you can see in the picture down the bottom, he's got some involuntary curling of his right fingers when playing. The type of dystonia I'm talking about is task-specific, which only occurs when doing a particular task. And there's a painless loss of motor control in a previously well-executed task. And often this then causes a decline in the motor performance and affects professional sportsmen and musicians, commonly causing a termination in their career. It's also being reported in typists, cobblers who make shoes, writers, and as I mentioned before, sports people. It can affect the foot, the hand, the embouchure, which is the mouth and the lip in brass and woodwind instruments. And in musicians, it's been reported in pianists, violin, guitar, flute, clarinet, horn, tablet drum, and double bass drum players. So With musicians' dystonia, we know it affects probably 1 in 200 musicians sometime in their lifetime, but this might be an underestimate because it's an under-recognized condition, and often musicians are reluctant to seek help early. When they did statistics, they found it can affect up to 14% of patients in a performing arts medical center in Hanover, Germany, and predominantly affects the male, and the age of onset is between the age of 30 to 40s. So often when people are at the peak of their musician or musical career. A writer's cramp also has quite similar age of onset, around 30s. It's also a task-specific dystonia, and there's abnormal stiffness or tightness of the arm or the forearm when writing, and this disappears when the patient stops writing. It can reduce the speed of writing and make cursive writing more difficult than printing writing. What happens to the muscles when there's dystonic activity? So when we study the onset and duration of muscle contraction during the performance of a task that causes a dystonia using what we call surface electromyography, as you can see on your right, there is unnecessary contraction of surrounding adjacent muscles needed to perform the task. For example, in the picture on the right, the flat line means less muscle activity, whereas a jagged line means the presence of muscle contraction. So during this electromyography, the person's doing elbow bending, and so during that time, it's normal to have bicep contraction, as you can see on the sort of third bottom bar here with the jagged activity. But during that time, there's also activity in the adjacent deltoid muscle, which moves the elbow up, and also pectoralis muscle up the second top line, and the neck muscles. And not only that, at the same time, there is also opposing tricep muscle activity. So tricep muscle, when it's contracted, it actually straightens the elbow. So it's fighting against the bending elbow task. And so during bending of the elbow, it's supposed to be relaxed. However, as you can see on the middle line, which is the fourth from the top, it's the tricep muscle, there is still muscle contraction during the bending of the elbow. And so this can lead to repetitive twisting movements or abnormal posture during a task performance. So what happens to the brain in dystonia? So when we look at the brain activity in patients with dystonia, we find there is abnormal excessive brain plasticity, which is probably a term you heard of quite commonly. And this is the ability of the brain to change the effectiveness of signal transmission within the brain circuits. So normal brain plasticity is needed for learning, consolidating memory, and plasticity is also recruited to try and compensate for any loss of function after a brain injury, such as a stroke. So when trying to learn a new skill, for example, trying to hit a ball with a tennis racket, the eye sends signals to the brain, which then tells the arm to swing back and be prepared to hit the ball. So in order to do that, we have to know where our arm is in relation to our body and in relation to the world. And for that to happen, we get sensory inputs from the joint and muscles in our arm, which then connects to the brain. And the integration between the vision and the sensory area of the brain then tells the movement part of the brain which direction to swing the arm and which muscles to use to swing the arm and which muscles should relax during the swinging of the arm. And so we practice hitting the ball several times in order to get the hang of it. And as we practice, stronger associations between the sensory and the movement part of the brain occurs in order to sort of create a more coordinated muscle contraction and also phase out less efficient muscle contraction. So it becomes more second nature. Whereas if there's too much brain plasticity, which is found in people who has a tendency to develop task-specific dystonia. And this can cause the formation of wrong associations between the sensation part of the brain and the movement part of the brain, and a failure to phase out less efficient muscle contraction. And gradually over time, this can also spread to influence the performance of other motor tasks. So the result of the formation of the wrong association between sensory part of the brain and movement part of the brain is that an abnormal sensory representations form within the sensory part of the brain. So normally the part of the brain that senses the thumb, the index and middle finger is actually separated from each other, as you can see on the sort of left of the picture, which is normal. However, with abnormal plasticity in a person with hand dystonia, there is a loss of separation between the fingers. And so there's no clear sort of border in between the individual digits. So this has also been found in people who have mouth and lip dystonia, or the embouchure dystonia. And the tongue and actually the lip part of the brain representation also overlap. And with retraining exercises and treatment, as you can see on the right, there is some mild improvement in the sort of separation of the sensory representation within the brain. So you might ask, what causes abnormal brain plasticity? But the truth is no one knows yet. It's called idiopathic dystonia because the scientists and doctors are so far idiots and they haven't figured it out. But what we know so far is that the conditions that influence the brain plasticities, and these are factors that influence the brain cell membrane stability and the flow of what we call ions that contribute to membrane stability across the brain cells, and also brain cell-to-cell communication activity called synapses. And all of these determine the level of brain cell electrical stability and discharge. And they also influence the ability of the brain cell to regulate their own excitability. So what might contribute to the development of this task-specific dystonia? So childhood brain development could. So we know that learning an instrument in childhood is less likely to have task-specific dystonia later than if you learned a musical instrument in adolescence. And also there's the contribution of genetics, as 20% of patients with musician dystonia also has a family history. In combination with also environment, for example, localized pain from overuse or having a nerve entrapment can also contribute to the development of task-specific dystonia. And also particular music, such as classical music with very tough repertoire with the need for precision and control, can also contribute to dystonia. Whereas jazz music, where you can improvise and there's less the need for precision and control, these patients have a lower incidence of dystonia. The other factor is a perfectionistic, anxious personality. This is more common in patients with task-specific dystonia. So some of the indirect evidence pointing to the overuse and overpractice of the hand can lead to task-specific dystonia come from trained monkeys who are trained to do repetitive hand activity, and over time with repetition, they also develop similar abnormal posturing and movement that looks like dystonia. And when their brain is studied, there's also abnormal brain representation of the hand area. So that's actually a sort of animal model of task-specific dystonia. And with the last 200 years, with sort of gradual the development of virtuosos who perform very technically demanding pieces or particular instrument that require more and more hours of practice every day and a near perfect accuracy in their performance. There is also increased recognition of musician dystonia in classical music virtuosos. And we also observe the pattern of musician dystonia also dependent on the specific technical demand of the particular music instrument that they play. So, for example, pianists and also violinists can tend to have like musician dystonia affecting the finger flexors, or particularly the left hand, involving the third, fourth, or the little finger. So the left hand is responsible for pressing on the strings of the violin and have to move very quickly during particular musical passages that are technically demanding, and similarly with piano as well. And most people being right-handed, the left hand sort of puts more demand on the left hand during musical performance. So as we mentioned before, some of the risk factors for musician dystonia is learning music from adolescence onwards compared to those learning in childhood. And people who start in adolescence have been found to have a smaller brain motor circuit than those who started earlier in childhood. And the other one is genetic that we mentioned before. So what have been some of the triggers for musicians' dystonia? So it's been reported a nerve entrapment or peripheral neuropathy has been noted to trigger musicians' dystonia, or a change in their practice technique from their usual practice methods, and also a sudden increase in the duration of practice being associated with it too. So I'll show you then some video examples of musician dystonia. So the first is ambitious dystonia. It's a video showing that there's a tremor of the lip when playing the tuba with leakage around the mouthpiece.
There's involuntary 1.5 tremors of the upper jaw that cause air leakage around the mouthpiece.
And the other one is a pianist finger flexion dystonia. So in the next video, you'll see some involuntary flexion of the little and the ring finger of the left hand when playing the piano. Okay, so this patient was then treated with botulinum toxin injection and also slowed down exercise retraining. However, he still decided to move on to a teaching career. So I'll just show you, this is about a month after.
This arpeggio, but now I can't. So.
Yep. So as you can see, there is less involuntary flexion of his left hand fingers when playing. So the next patient, he had guitar and keyboard playing dystonia. It affects his right, middle, and ring finger with involuntary flexion.
Yep.
Then the next one is drummer's dystonia. So this gentleman has right thumb tip involuntary flexion when he's playing the drum. and then the drumstick falls out of his hand, and he's just imitating playing the drum using one of the chairs in our hospital. So he can't bring his drum kit with him. The treatment so far is in a large musician dystonia clinic. In about 50 patients, there's about 50% improvement with a combination of medication like trihexyphenidyl or Artane, which can reduce the abnormal plasticity. But if the dose is too high, there is temporary side effects like constipation, dry mouth, and forgetfulness. The patients who have tremor, some of them can benefit from a beta blocker medication just prior to their musical performance. And as you saw, the botulinum toxin injection can also help with musicians' dystonia patients. This causes and reduces the abnormal plasticity in the brain. However, if the dose is too high, it could be temporary side effects like weakness in the muscle that's injected, bruising or infection. And some of the other sort of changes that could be made is ergonomic changes, such as having a hand splint or cooling the mouthpiece of the brass instrument when playing, and retraining exercises which could be monitored by a very strict teacher, which is called pedagogue, and physiotherapist who's trained in musician dystonia, or slow down exercises that we mentioned before. And the botulinum toxin injections work well together with these retraining exercises. So just to show what some of the orthosis look like for things like writer's cramp. And some of the exercises have been shown to help the keyboard players. However, these people have to do these exercises daily for at least 6 to 12 months to see some benefit. And one participant had to do this every day for 3 years in order to return to professional playing. So for ambitious dystonia, these are some of the resources I give to my patients, depending on what instruments they play. As to which the strict teacher has experience with musicians' dystonia. And studies have reported that limb immobilization with hand in a splint and simple practice exercise had improvement in the dystonia rating scale. And these improvements were from moderate to marked improvement in 7 out of 8 patients. And with other so splinting and retraining, these involve finger splinting to the unaffected fingers and retraining of the affected finger daily for 2 to 3 hours a day for 2 weeks. And about 8 out of 11 musicians improve after removal of splints and gradual return to playing. With writer's cramp patients, there's been retraining of the sensory motor integration to try and refine the processing between the 2 areas of the brain and to restore the task-specific skill. So learning to read braille or emboss letters with fingers on a daily basis has been found to reduce writer's cramp in a small study. So going on to some other sort of reported therapies that's been suggested to help in smaller studies as well is non-invasive repetitive brain stimulation. So in writer's cramp, it has helped with writing pressure for about 20 minutes in 6 out of 16 patients, reduce also pen pressure in 7 patients in a study, and mild improvement in patient-reported changes in 9 patients. And there's only 1 case report if they had brain this magnetic stimulation every 2 days for 5 weeks with daily retraining exercises. They had sustained benefit for 1 year. Then for musician dystonia, there's been reports of a combination of direct current magnetic stimulation with rehabilitation over 2 weeks, and they found the combination had a more improvement in dystonia severity compared to the one with stimulation alone without neuro rehab. However, they did not follow up these patients long term, so we don't know what the duration of the benefit is. And there's only been one case where they underwent magnetic stimulation for 5 consecutive days with 1,200 pulses, and they reported 80% improvement, which lasted for 4 months. And with repeat stimulation, there was another 5 months of sustained improvement. So I'm talking about deep brain stimulation surgery. Generally, this is reserved for patients if above measures that mentioned has not helped and they want to go back to musical performance career. The benefit of this surgery is that the side effects are reversible by turning down the stimulation, such as persistent pins and needles. However, it does have a 1 to 2% risk of death, stroke, or bleeding in the brain. So it's something you need to be considered very carefully before going ahead. And so far, no clinical trials has been done in occupational dystonias, and we only have case reports. So that means the true successful rate might not be known because people don't tend to report the unsuccessful cases. So there's been old neurosurgery called thalamotomy, which is burning part of the thalamus with thermal coagulation. It has more irreversible side effects that we mentioned before, with pins and needles or weakness. And so far, it's been successful in about 16 patients, which are case reports of writer's cramp in a Japanese and Polish group. So my next slide is my last slide before questions. So what's been on the horizon in terms of research in task-specific dystonia? So it's been a research in clinical trial using Xeomin, which is a 2 months duration of botulinum toxin, and preliminary results of 16 patients with musician dystonia found there was improvement in musical performance and reduction in dystonia severity in the treated group compared to placebo. And the more frequent injection every 2 months is allowed for those whose benefit from the current Botox injection, which is every 3 months, is a lot less than 3 months. There's also a clinical trial, repetitive transmagnetic brain stimulation underway in the US for writer's cramp, and a clinical trial of a 9 months duration of this DAXI botulinum toxin in neck dystonia. So this toxin actually lasts for about 5 to 6 months instead of 3 months. It just completed recruitment about 4 months ago, and the data is being analyzed. But looking at the initial results, which is being published in a poster in this week's International Movement Disorder Congress, it shows that there's about 30% improvement in the pain, severity, and disability from neck dystonia, and this improvement lasted for 5 to 6 months. So hopefully it should be coming soon to Australia, so then people don't have to have as much frequent injections. And also there is a study looking at the safety and efficacy of deep brain stimulation for focal hand dystonia in the United States. So I just want to say thank you to all my mentors, Dr. Victor Fung, Neil Hunt, and the rest of the Movement Disorder Unit, and our fellows for the videos, and also the Dystonia Network Australia organisers, Lorraine, and Kerry, Robin, and Denise. So time for questions.
Hi, I just wanted to ask if it's a type of dystonia that is likely to spread to other body parts, or if it stays in the initial affected body part.
Yeah, it's a good question. We tend to find it doesn't tend to spread to the other body parts that are not repetitively using or performing a repetitive action. However, if the patient, say, if they have right hand musician dystonia, if they then try to compensate by using the left hand to try and perform the complex repetitive tasks, they can also develop the left hand dystonia as well.
I see. Okay, thanks.
Can I just ask, the new Botox you were talking about, is that for all types of dystonia or just the hand or musicians?
So far, it's been trialed in the neck dystonia overseas. It's found to be safe and effective. And so usually what happens next is they'll try it in the other forms of focal dystonia, like hand dystonia or other types of dystonias.
Wow, that'll be good.
Yeah.
I was just wondering if there's a chance of the dystonia disappearing without treatment. Does this ever happen?
So much for the musician or the task-specific dystonias, whereas I think in a study of things like cervical dystonia, up to 10 to 14% of people go into remission, but it can also relapse as well. Yeah.
Any other questions?
Jen Carey?
I was wondering if if you could have forearm dystonia in something like knitting, things like that, when you're constantly doing things that you need your hands and your arms for.
Yeah, I'm not sure. I have to Google that one. I'm sure it's never been reported.
Well, I know some people that have, like, their forearm really goes tight, and their knitting is tight like a knitting machine.
Okay.
And there's no, you can't get any holes in it. It is so tight, and the arms and the hands hurt.
Okay.
They go very stiff.
I'll be interested to see them.
I live in a house of golfers, and you often hear of the yips.
Yips.
That's right.
Yes.
Yeah. That's also a task-specific dystonia. Yeah.
Yeah. Is that all the questions? Yes.
I think so.
Yeah.
I'd love to say thank you very much, Dr. Chang. We would like to extend our appreciation and on a very informative presentation on occupational and musicians dystonia. And thank you for taking the time and effort and your continued commitment to dystonia and DNA.
Thank you so much to you all for inviting me. I certainly learned a lot from this experience. Yes.
Thanks very much. Thank you.
Thank you.
Thank you.